Thanks, Rohit. I'll tweak the topic a little bit. So, I was supposed to talk on selecting the ideal lubricant or something, but instead of that, I'm going to talk on selecting correct eye drops for dry eye. So, just to widen the horizon a little more. So, when we talk about dry eye, we classify the dry eye depending upon aqueous deficiency, evaporative dry eye, and so on and so forth. But are we actually talking about the root cause when we talk about aqueous deficiency or evaporative? Well, we are not talking about actually cause of the dry eye. Same way, if we are talking about the diagnostic test for dry eye, the gold standard test of our questionnaires, quality of vision and ocular surface staining, T-birth, Sherman's, and all those things. Whenever we use all these things, do they actually find out the root cause of dry eye after this thing? Well, no. It will just tell you tears are there, not there, sufficient, evaporating faster, and these things. Same way, if we look at the treatment, when the standard treatment of lubricants, punctal plugs, autologous serum, and whatever we use, are we treating the root cause of the dry eye? No, we are not treating the root cause of the dry eye, we are just treating the effect of that. So, are we actually treating dry eye? This way, we are not treating dry eye, we are just managing dry eye, we are just putting something on the surface of the eye. So, how do we go about it? First of all, we need to understand the pathophysiology of the dry eye. Fortunately, with the newer classification, the definition of the dry eye, we understood that there are certain important factors in the pathogenesis of the dry eye. One is hyperosmolarity, apoptosis, inflammation, and tear film instability. So if we pick up these things and if we try to pick up where there is a fault, maybe our treatment would be more customized and better. So let's start with hyperosmolarity. Again, it's quite simple. In case of where the tear film is abnormal, where evaporation is higher than the secretion, or the secretion is lower, in such kind of scenarios, tears evaporate. The preocular tear film becomes hyperosmolar, and it takes away the water molecule from the cells and dehydrates the cell and finally kills the cell. At cellular level, when this happens, it actually destroys a lot of ocular surface cell, and which itself leads to inflammation. Within a couple of days, actually it starts showing up even on the biochemical level also, where we can detect the biomarkers for apoptosis very early in these cases also. That means there are some damages which is occurring on the surface quite early. Clinically, there are some instruments like osmometry where we can detect the osmolarity changes on the surface. Fortunately, it's a very simple test and which should be done first in the OPD before doing anything else. However, it has its own problem, as it has quite a significant variability. Test retest variability. Hence, if you see the graph here, between normal and abnormal, there is a lot of crossover. Hence, it's quite possible you may have a dry eye patient, but you may have still normal osmolarity value. Or same time, you may have abnormal osmolarity, but patient may not have dry eye. So because of this thing, there can be sometimes issue of treating the patient just based on this test. Now, if the hyperosmolarity is so important, why can't we just reduce the osmolarity of the surface by using hypotonic eye drops? Well, there were such hypotonic eye drops earlier, where the hypotonicity was said to be increasing the volume of the cell and which will hydrate the cell again. Unfortunately, this hypotony, whatever we create on the surface, comes back to its previous level within a couple of minutes time. Hence, it does not work when we try to rehydrate the cell by giving hypotonic solutions. So what we can do is we can prevent the damage of these cells by having some osmoprotecting agents. These osmoprotecting agents are there, always there in the science, where they are used in biology and multiple other fields where we prevent the damage of the cells as well as these structures by preventing them to expose to the osmolarity value. So there are certain molecules like glycerol which rapidly comes inside the cell and goes out faster. Erythritol which percolates inside the cell little slowly. The same way goes out also little slowly. And L-carnitine which goes in slowly, comes out slowly. So with the combination of all these things, we actually can manipulate the surface like that it does not damage the cells. Now, osmolarity comes into picture when it starts killing the cell. When it starts killing the cell, it starts inducing inflammation. The inflammation on the surface of the eye due to dry eye has been widely studied. Thanks to Professor Fluckfelder, we now know that it's not a normal disease which we thought earlier. It's quite a complex situation which is mediated by T cells and inflammatory mediators like MMP9. It's white inflammation. The eyes are white, but there are a lot of inflammatory mediators in the TFL. So how do we can study? Well, we can actually study with some simple instruments like these RPS kit, which detects the MMP9 level. Now, Fluckfelder's group again showed us that most of those cases where they were dry eye had MMP9 level more than 40 nanogram per ml. So, the kit here, what we have, it actually detects whether the level of the MMP9 is more than 40 nanogram per deciliter or which is less than that. Now it's very simple, like a pregnancy test. Do it in 10 minutes in the outpatient and it will tell you at least whether this is more than 40 or not. Now though it's not a perfect foolproof treatment as the damage can occur less than 40 nanogram also, but we still have something in our hand which at least detects when it's more than 40. So how do we use that? In dry cases, when we detect the level of these MMP9, when we find the MMP9 levels are not very high, we know that not much of inflammation is there on the surface. We treat them with lubricants and punctum plugs and those things. But when we find that MMP9 level is high, it requires the use of anti-inflammatory molecules. And these anti-inflammatory molecules we know are something like cyclosporin or tacrolimus. The cyclosporin, we know that it's best used in mild to moderate cases. So again, when we have inflammation, early inflammation, or when it's not totally burnt out case of dry eye, it's very important to select these kind of eye drops which can help us to reduce inflammation and further prevent the damage. Same way, similar to cyclosporin, tacrolimus was in use for multiple other applications. It is actually quite widely studied in veterinary science and dogs. It has been clinically used for quite a long time. There are quite good studies, prospective trials going on, but same time we have to remember there are certain advisories which have come out which tells us that we should be careful when we use such kind of molecules. There can be potential chance of surface neoplasm. So cyclosporin can reduce the MMP9 level and may not work in all the cases. We have to be selective. It should be combined with lubricants which is not mutually exclusive, and we have to wait for a little longer time to detect the outcome or the results. When we talk about the pathogenesis, again Natasha touched upon this, then TFM instability is a very important part, and lately we have seen MGD and TFM instability has been introduced into the field of dry eye as very important factor which leads to surface damage and dry eye. There are multiple reasons why you can get MGD or you can get the Meibomian gland dysfunction, which is hypersecretory or secretion may be low. There are a lot of reasons. Unless we treat them, we'll not be able to take care of them. But very importantly, like how Rishi said, earlier when we had MGD, our treatment we were taught was that warm cup versus lid massage. Now how does it help in selecting your lubricant when we have meibography, or earlier I used to do with autoreflectometer? Well, if we have an MGD case, we do a meibography. If Meibomian glands are normal, we surely can do lid massage, warm compress and all these things. But when we find there is significant loss of Meibomian gland, whatever you keep on doing, you keep dancing on these leads, nothing is going to come out. So in such kind of cases, it's very important to remember that we may have to supplement the oil portion of the Meibomian secretion, which is not there in most of the routine lubricants. Unfortunately, in our country, we still don't have those lubricants which are available in the oil emulsion form. But we do have ointments, which are liquid paraffin based ointments, which can be used along with this thing, which can help us in taking care of such kind of cases. To summarize, we need to study the etiopathogenesis of dry eye to correctly select our eye drops or the medication which we are going to use. Hyperosmolarity is a very important mechanism of a dry eye. Unfortunately, cannot be treated with the hyperosmolar molecules, but it can be treated with osmoprotecting agents which can prevent the further damage of this hyperosmolarity. Inflammation in dry eye is a very wide subject, and anti-inflammatory molecule, whenever there is a high inflammation, must be used on these cases. Thank you very much.